I'm an Anishinaabe Kwe, or an Ojibwe woman. My family comes from Lake St. Martin, Manitoba. My community lived experience is that of an urban one here in Hamilton. I also have Celtic settler ancestral roots from County Down, Ireland. I'm a Nidanas, daughter, a Inama, mother, Nokomis, grandmother, Shogo, auntie, Mino Glusigad. It's a beautiful day here in Hamilton at this time. So I speak the little bit of Anishinaabewin that I know as a daughter of an Anishinaabe Inama mother who chose not to teach her children her language, although she was a fluent speaker. But more and more, I situate my ongoing learning or reclamation of Anishinaabewin as a measure of linguistic justice, and recognizing that this is the experience of many of our Anishinaabe brothers and sisters, and indeed Indigenous peoples across the country whose language was rejected, and many who made that choice of rejecting their language or protecting their children. And so it's important that I now talk about this whenever I can, because the focus of my research, I've mentioned in the introduction earlier, is focused on harmonizing health systems and understanding and amplifying the voices of Indigenous communities and women about their needs and perspectives related to cardiovascular disease and stroke. So our own concepts of health and well-being are in our language, and how we relate to the world around us is in the language. And so I see myself as a lifelong learner, and the degrees have been important, but learning my language now I uphold of the greatest importance. And so thank you once again for inviting me to participate, and thank you to my colleagues for the excellent presentation. I look forward to reading that report more fully. I'm hoping today my contribution will help those who are in attendance to understand the challenges and the opportunities faced by Indigenous health practitioners for blending Indigenous and Western knowledges into their healthcare practices. And so I think what you can see here is just an acknowledgement of the aspirations and tensions that we experience as Indigenous healthcare practitioners. And of course, today I speak only from my own experience. I know of healthcare practitioners who are very satisfied to fulfill their professional obligations, according to their designation, and just be a healthcare practitioner. But I know more who experience these tensions. So this is indeed where we have come from, and I will skip over some of the information in my slides in deference to what's already been presented and in the interest of time. But many Indigenous healthcare practitioners choose healthcare as a profession because they want to help their people. Some want to return to their communities to work, and some came to healthcare as a second career or later in life after having children. For myself, it was my mother who encouraged me to go into nursing. I didn't know what I wanted to do, and it was actually her dream to be a nurse. She grew up at that time, it was a small fly-in community, and she regarded the healthcare practitioners, especially the nurses, as she held them in high regard. And how she explained it to me was, you should be a nurse. You will always be respected. You will always have a job, and you will be able to travel. And she was right on all three counts. And I always honor her because she strived to ensure that all four of her children had higher education. And so she was an integral part of helping me to find healthcare. I found out much later in life also that my grandmother was a midwife in the community. And when somebody told me that, I confronted my mother and said, how come you never told me that? And she said, because that's not what we called her. We didn't call them midwives. We just called her Granny who brings the babies. And so she was quite perplexed as to why I didn't know that. So, it's important that, we are seen as helpers in the community. And, somewhere along the way, healthcare professionals have become elitist. To our family and our community, sometimes it's just, that we're helping others. And that's really the true nature of healing ways. So some people do want to return to their communities to work. So I'll come back to that later. But whatever the reason, many of them experience a tension between who they are as Indigenous people and how they have been taught to practice as a nurse or a physician or a dietitian or a physiotherapist. For many, this begins in the academy in their post-secondary health science program. Often they can't see themselves or their culture in the program curriculum. They may experience microaggressions from their non-Indigenous peers when they attempt to express their indigeneity in the classroom. And there may be a sense of isolation when professional colleagues' standards of care are bereft of policy that would allow them to integrate their own Indigenous ways of knowing and being into their clinical practice. So for myself, for my nursing education, I think I would have to summarize, I didn't know what I didn't know. And so I went blindly through, never really seeing the absence, if you will, but thinking that this, not questioning what was being taught, not recognizing what was missing. But when I went back to do my higher education, my graduate work, I felt very isolated in what I was trying to study. I couldn't go back to health sciences. I wanted to be at McMaster in Hamilton, and there were no supervisors. There was actually no Indigenous faculty within the Faculty of Health Science at the time, and which led me to going into medical anthropology, which I felt was going to be a perfect fit for what I wanted to explore. I felt I would have the room, the boundaries in that area, in that discipline, and my health science background and training. But it was an isolative experience, and I did have to challenge in many different situations, and I would turn to my Indigenous scholar colleagues on campus who were not health science oriented, but it was something at least. And so I just want to talk a little bit about the historical perspective here. So the phenomena of what I just described is well documented in this text that you see here, written by Mary Jane Logan McCollum about Indigenous women work in history. It's an excellent work, and I highly recommend it if you haven't seen it. So she talks, one of the chapters, the history of the Canadian Indigenous Nurses Association, which is previously known as the Registered Nurses of Canadian Indian Ancestry. And McCollum captures the poignant truth that a small but significant minority of Indigenous nurses overcame considerable obstacles to attain nursing education and employment, and did so in spite of educational policies that prepared Indigenous women for domestic work and generally discouraged them from pursuing higher education. And so 14 Indigenous nurses came together in Montreal on the Ganawage Reserve to share their own stories as Indigenous women trained in a Western education system that prepared them to practice only within a Western healthcare model. And so this was an important movement of resistance to patterns of Indigenous education and employment that disempowered them as Indigenous healthcare workers. And so the primary goal of the organization, which we call CINA now, that this was to improve the health of Indigenous communities and to position professional Indigenous nurses as critical components of the Indian health field that was emerging. And so their aim was also to track and represent Indigenous people in the profession and to shed light on problems related specifically to government-controlled healthcare, provided at that time by the Medical Services Branch. So here we are 45 plus years later, and the organization continues to be a leader in aspiring to create systemic change. And several other Indigenous healthcare professional associations have emerged over the years as well at both the international and national level, including the Indigenous Physicians Association of Canada, or IPAC as we call it, the Indigenous Midwifery Association, also here in Canada, and there are some others. So an important critical issue here in the historical perspective, though, as McCollum writes, is the notion of how Indigenous history is captured and how Indigenous scholars and professionals in this case are treated. For example, McCollum points out that certain assumptions about Indigenous people and Indigenous cultures have led also to the assumption that modernity developed quite apart from Indigenous people. And she situates this discussion with the poignant question, what if we take as a premise that modernity is not something that Indians by nature or by tradition are prohibited from partaking in and indeed creating? And she draws from Deloria's work, who explains how Indians were produced as unexpected in a modern setting. Their authenticity was drawn from their location outside of modernity in an unspecific primitive past. And she goes on to include Audra Simpson's work, who talks about the trap of putting it in an ethnocentric perspective. So all that to say that often in this situation, McCollum writes extensively in her work about how we are often still marginalized as Indigenous health professionals and Indigenous women. And so that could be a whole topic on itself, but I'll move on to the next slide. So what's already been talked about in my colleague's presentation is the barriers that we experience. And so for those of us who are currently engaged in systemic change within the academy, and I think that it's very difficult for an Indigenous health professional to not be involved in some level of systemic change. You are called upon to sit on committees, to lecture, to fill the gap of the lack of Indigenous faculty in university settings. Often you're the only unpaid person at a table of high-level systems change folks, and it can be very challenging. But there are many of us who continue to do this work because we have to. It's like it can't be ignored, and we have to create a situation that is improved for the generations coming up behind us. And so we're working hard to improve access to programs, develop new or enhance existing curriculum, and eradicate discrimination and racism. And so this slide just speaks to Article 2 of the United Nations Declaration on the Rights of Indigenous Peoples, which states that Indigenous peoples and individuals are free and equal to all other peoples and individuals and have the right to be free from any kind of discrimination in the exercise of their rights, in particular, that based on their Indigenous origin or identity. And so this kind of international legislation, which actually also informs the Truth and Reconciliation Commission of Canada, is extremely important to us in our work because it provides a legislative framework within member states to draw from and to make cases and rationale for the work that we do. And so this is a picture of me way back when we wore crisp white uniforms and funny hats. But I draw on this notion of my story from time to time, and you can see there I've tried to put a thread of what my path has been to where I am today. I think advocacy is threaded throughout it, but I do tell my story at a personal level in many situations because it's important for those who work in policy, for decision makers, for those working in the academy to understand the experience of Indigenous health professionals. And I think my story is probably similar to many others where, I was called upon to be in leadership roles and on committees and in decision-making situations because of, being a person with an Indigenous identity. And I've also been in multiple leadership roles and, often they're very challenging. It's a climate of uncertainty. It's a climate of advocacy. It's a climate of tension. Resistance. My former colleagues mentioned the colonial impact, lateral violence. So it can be very challenging, and my story includes all of the above. But I have to say that it's also, I find Indigenous health professional colleagues that I work with and people in communities who are doing the community level health related work are very passionate about what they do. And nobody follows this path and stays on it unless they are impassioned. And so I've been very fortunate also to be on this path. I usually tell a longer story about it, but in the interest of time, I'll move on. So, I guess the release of the Truth and Reconciliation Commission of Canada's final report provided a window of opportunity to change the status quo in this regard. As part of their 94 calls to action, of course, as probably most people on the line are aware of, but I don't take anything for granted anymore because I have asked people in certain circles if they've heard of the TRC, and many people have not. So I don't assume that now, but there are many resources online if anyone in the audience does not know too much about it. And so if you just Google Truth and Reconciliation in Canada, those resources will become available to you. But essentially, call to action number 3, the Commission called upon all levels of government to increase the number of Aboriginal professionals working in the healthcare field and ensure the retention of healthcare providers in Aboriginal communities, provide cultural competency training for all healthcare providers, and further, that those who could affect change within the Canadian healthcare system to recognize the value of Aboriginal healing practices and use them in the treatment of Aboriginal patients in collaboration with our healers and elders where it was requested. And so there is a need for us as Indigenous healthcare providers. I also talk about the notion of decolonizing our own minds, because in order to do this work, where most of us have been trained in and educated in systems that had no Indigenous health content, for example, there is this need to unravel what we have learned and to be thinking about these things and in order to do this work. So I'll come back to that. So this basically speaks a little bit more to what I just mentioned. So this next slide speaks to what my colleagues were identifying and what other Indigenous healthcare professionals were speaking about, and that is our perspective or our worldviews are very different between Western, Eurocentric worldviews and Indigenous worldviews. And as you can see, I think what stands out here is the notion of one truth and the hierarchical principles and value of similarity by repetition that have made their way into the dominant system. So we see it in the multiple choice tests that hierarchically categorize our knowledge. We see it in the authoritarianism in the way that medicine has historically been delivered, revering doctor expertise at the expense of the patient's expertise. We see it in the medical system's value for those expensive, industry-funded, profit-supported, double-blind scientific studies, for example. And so that notion of one truth, for example, is not part, what I have learned, of Indigenous value systems. And so, you know, I've heard Senator Murray Sinclair, the Chief Commissioner of the TRC, reference this issue as the tall mountain to climb in health, and in fact, in many other sectors. And as my colleagues talked about previously, kind of integrating these two systems and beginning to respect that both have something to offer. And so this next objective then is to also talk a little bit about wise practices employed by Indigenous healthcare practitioners in accessing and utilizing Indigenous knowledge and traditional practices to optimize the health outcomes of Indigenous patients. And so the TRC describes reconciliation as an ongoing process of establishing and maintaining respectful relationships at all levels of Canadian society. And as I mentioned, they draw heavily and endorse UNDRIP as an appropriate framework for doing so. For Indigenous healthcare practitioners, it's also this notion that I heard framed recently, again, about decolonizing our own minds, casting out the tyrant within. And I draw in the words of Senator Mary Jane McCallum, who talked about this experience. Senator McCallum is a dentist from Manitoba, and she recently was a keynote at an Indigenous Health and Research Conference that McMaster hosted with our local communities. And she talked about this notion of the tyrant within, and it really resonated with me because it's just something, you know, that you're always dealing with. And when I think back to my early days of practicing as a young nurse, I remember intuitively asking my patients as I was making my rounds, how was their spirit today? And I don't know where that came from. They didn't teach me that in nursing school, but it was just something that I felt that's where I started from in my assessments. And when I was working on a busy surgical unit, it always connected us closer as healthcare practitioner and patient. It used to irritate my team though, because it would take us longer to do the rounds because the patients would open up. And so I've shared that story many times, and that was just an intuitive response. And as I went on in my career, always recognizing this tyrant within and having to unravel, whether I was at a policy table or a decision-making table or in a research project. And I talk about this in my own research. I call it the diaspora of Indigenous knowledge. And as an experience where the adoption of non-Indigenous or mainstream biomedical values, you know, became that dominant theme in who I was and how I practiced, because that's how I was taught. And I saw it then as interfering, you know, in a way that we made less connection with our patients because of that. So I wrote about that in my dissertation. And in the work that I read, I acknowledged that the cultural knowledge distortion occurs at that point because we struggle with understanding what we want to say based on our indigeneity and who we are as Indigenous people. And previous presenters mentioned that. We are now bringing in the teachings we've heard, the protocols that we understand, the deference to elders and what they have to say, for example, or in some of the medicines that you have learned from family. And so to know that that kind of practice exists, or that there are words in the language that are different from health science that you would like to use, creates this cultural knowledge distortion. And my thesis was looking at health literacy, so I framed this as a diaspora health literacy for Indigenous peoples. And so I could go on and on about that aspect, but I think that's actually the critical piece that brought me back to graduate education, because the only way I could talk to folks about health literacy for Indigenous populations was within the frame of reading, writing, and arithmetic, or from that educational perspective. So that's what led me down this path. And my sense was that it was in the language, that my query was, if you had your language, if you had your teachings, were you health literate, an Indigenous person? And so it led me to this work on harmonizing healthcare systems, and also to teaching, educating non-Indigenous healthcare providers as to how they could work for Indigenous peoples. And my premise was that if we could address this cultural knowledge distortion, we could guide our patients, our Indigenous patients, and hopefully increase their sense of personal agency and self-care management with chronic illness. And so this is just a little bit more on UNDRIP, which basically the key point is here on Article 33, which recognizes that respect for Indigenous knowledge, cultures, and traditional practices contributes to the sustainable and equitable development. So it's not just a nice thing to do for Indigenous peoples. There is evidence that it increases our development and our health status. So when we think about the whole notion of Indigenous science as a form of Indigenous knowledge, this refers to the science of Indigenous cultures. It's a way of seeing and knowing that's dynamic, holistic, intergenerational, and time-tested. It's existed for thousands of years, thus developing sophisticated modes of knowledge transfer that have enabled its survivance. So it's more than mere survival. It's a way of life that nourishes Indigenous ways of knowing. But as mentioned previously, it has been devalued and based on Eurocentric truths, as it were. So this speaks to, as I mentioned, Article 24, which is Indigenous people having the right to traditional medicines, maintaining their health practices, the biodiversity elements of NDRIP, and so forth. And so, when I'm talking, when I'm lecturing, or, trying to educate other networks, it becomes less important for me to try to educate them in Indigenous knowledge and traditional healing. It's such a huge area, and I feel like we're just at that little tip of the iceberg. I think, it took a civil society movement to recognize that Indigenous peoples had culturally relevant social determinants of health, but the uptake has not been great. We still have a lack of recognition that self-determination and land are two critically important social determinants for Indigenous peoples that were cited in the WHO report on social determinants. So my goal is just to raise awareness at this point, but we are entering into a time where we're going to grapple with this. And so I do talk a little bit about Indigenous knowledge and traditional healing to raise awareness that it still exists, and to lead into this notion of how it influences our health. So this, again, is another article in UNDRIP that talks about the practice of our Indigenous knowledge. And so Indigenous nurses, doctors, therapists, mental health workers, we are Indigenous people. And thus, we have the right to manifest, practice, develop, and teach our spiritual and religious traditions, customs, and ceremonies. And so I find that, this is a huge challenge for us as Indigenous practitioners, because we have been scared into abiding by Western health professional organizations that guide our practices and maintain our licenses. And we live in fear that we're going to contravene these rules and regulations. And also it was mentioned earlier that we fear being criticized by our peers. But I think for me that feels like that's less and less, and we're upholding each other in this work. But yeah, I think that we are starting to see some systems level change. For example, the Royal College on Physicians and Surgeons has now released an Indigenous health primer, and they are working on that next layer of adjusting policies, but they've mandated that they have to have Indigenous health education, for example, and a recognition of Indigenous knowledge in traditional healing. This is also happening in the nursing environment as well. And so just looking at the time, I just have a couple of more slides because I'm sure that there are questions. But this picture, which is a beautiful piece of art, encapsulates the people of the three fires and the seven grandfather teachings, the Anishinaabe. I just centered this as a being of an Anishinaabe woman that, you know, each of us, as mentioned, there are diverse Indigenous cultures, and we all aspire to our own languages, our own tribal customs and healing ways and Indigenous knowledge. And so it's a lifelong journey as we attempt to integrate what we know and what we're learning into our practice. This is a little bit more UN information. I'm going to go to the next slide. So I talked a little bit about the need and the importance of language. Again, just to recap that a lot of what we know about health and well-being is in the language in our traditional teachings. And so the advocacy work that's been going on to uphold our languages, Kajeti elaborates on this topic. He talks about language as being our symbolic code for representing the world that we perceive with our senses, and that the meaning is not connected solely to intellectual definition, but to the life of the body and the spirit of the speaker. And that at the deeper psychological level, language is sensuous, evocative, filled with emotion, meaning, and spirit. And in its holistic and natural sense, language is animate and animating. It expresses our living spirit through sound and the emotion in which we speak. And in the native perspective, language exemplifies our communion with nature. And so for those who have not had access to their language growing up, for the reasons that I mentioned previously, once you experience this at that spiritual level, there's no going back. You strive to continue to learn and to integrate it into your work. And so this story, Basil Johnson, an Ojibwe elder who's now passed to the spirit world, has written extensively about Ojibwe culture. And he talks about storytelling and how stories embody beliefs, attitude, and insights to life, being, and existence. And I'm constantly promoting the storytelling methodology in research and teaching and in relational development with communities and, of course, with our patients. This next slide, making space for Bimaadiziwin. So in my PhD dissertation, this was an important element of going inward, as I call it, and as, you know, addressing that tyrant within, to explore and situate myself in what I knew about Indigenous knowledge. I do share a very personal story, which I'm not going to take the time to do here today, but it was a personal spiritual experience that brought me to that experiential understanding of Indigenous knowledge and the importance of it to me in my work. As healthcare professionals, I think that this consciousness raising is a different experience for everybody. It's fraught with barriers, structural violence, systemic racism, criticism from our own. But everybody, I believe, you know, starts this consciousness raising at some point in their career. This next slide is a visual that articulates my dissertation. And that essentially, you can see in the bottom, I situate non-Indigenous healthcare providers as cultural brokers in that green circle. And I advise them that they don't need to know everything there is to know about Indigenous knowledge or traditional healing. They just need to work with us, both the patient, elders, healers, Indigenous healthcare practitioners, to create an Indigenous therapeutic relational space, which you see in the center there in the blue. So this depicts a medicine wheel, and we always start in the east, and you can see that on the right-hand side. I apologize because the slide is a copy, but it's basically about an assessment that's done in collaboration with the patient, with the elders, traditional healers, and healthcare professionals. And if that collaboration can be attained in that respectful relationship, then what it does is it propels the patient around the wheel to the northern direction where they achieve Nibwakawin, or wisdom and empowerment. And in this time of self-management of care, this situates the patient to be at their best in terms of increasing their personal agency and being able to take care of their chronic illness. In this case, it was cardiovascular disease, but that happens with chronic illness. And so this talks a little bit about storytelling methodology again. And so I'm not going to go into great detail there. Slides will be shared and you can look a bit more about it. And then the next slide talks about my Indigenous Women's Heart Health project. I'm currently the Heart and Stroke Foundation Early Career Chair, funded by Heart and Stroke and CIHR. And so this draws on storytelling methodology, and over 4 years, working with 3 Indigenous communities, the Mississaugas of the Credit First Nations here in Ontario, Lake St. Martin First Nations in Manitoba, and an urban Indigenous health center. And the idea is to gather information from multiple sources of storytelling circles and Indigenous women and leaders gathering to understand the resiliencies and the strengths that those women brought to their work, and how they addressed adversity and became leaders. We'll be talking to traditional healers and elders, and the ultimate activity is to create a curriculum that will hopefully engage non-Indigenous healthcare practitioners to work more effectively and in a more culturally safe way with our women. And then we also hope to educate young Indigenous women and share this information so that they too may benefit from understanding the information that we learn. And so it's very exciting. It's very challenging in this time, recognizing where communities are at. We accept that research is not high on the agenda, and that as Indigenous healthcare practitioners and researchers have to pause and turn our heads and open our hearts to Indigenous communities who, the complexities and the scale of their risk in this current COVID-19 environment. So it's a little bit challenging to talk about. It almost feels like I'm talking about the mundane right now, but it is what it is, and we strive to support them and bring our gifts with us to do this work. And so this second to last slide then here just speaks to this notion of authentic Indigenous partnerships. And in my work with SINA, we came about this in a self-reflective conversation with ourselves. And that was, as I mentioned earlier, kind of recognizing and understanding that we receive many labels and titles, and we're put in many boxes as BSCNs, nurse practitioners, RNs, doctors, clerks, whatever the case may be. But we are all Indigenous people as healthcare practitioners, and that we have the right and we have the wisdom. We carry it through our ancestral ties. We bring it with us to the environments, whether we're really aware of it or not. Just that relational approach that we bring to our work and the time that we want to take to engage in our work. We bring it in spite of the Western restrictions in many cases. And so I uphold my Indigenous colleagues, and I encourage you to perhaps send in your questions or your examples of how you do that. You can type them right into this webinar, the little ways that you're bringing that to your practice. There are many, and I was very pleased to hear the previous presentation, and it gives me hope. It makes me feel good inside that I'm not so alone. Leadership in this field is so challenging because you often look to the left and you look to the right and there's nobody to talk to about it. So anyways, I have many colonial moments, as I call them, where I'm talking about this to groups, committees, lecture halls, and I can see people yawning, checking their Facebook, or at that blank stare. And I have sometimes what I call these colonial moments, and I feel very vulnerable. But I uphold the National Collaborating Center on Aboriginal Health and your staff for the very, very good work, all the great work that's come out of your organization. And I uphold everyone online and encourage you to become institutional allies for our Indigenous healthcare professionals. Last slide is a picture of my mother's hand and my first grandchild, my granddaughter's hand. And it was just that moment that kind of captured that connection between, for the next 7 generations to come. We have to change things, and we're all a part of it. We have to do it together. Chi miigwech.